Good afternoon. My name is Noelene Moonsamy, and I'm a family nurse practitioner and full-time faculty at Samuel Merritt University's F&B program. I'll be sharing my DNP project, the Ubuntu Project. Ubuntu is a South African Shona word meaning humanity. In November of 1860, the British brought my foreparents from India to South Africa to work in the sugarcane plantations as indentured laborers. You see, slavery had just been abolished, and indentured labor was basically the new legalized term for slavery. My great-grandparents left the oppressive caste system in India in search of a better life in South Africa, only to find slave-like labor and apartheid to follow. My mom grew up in Sophia Town, a bustling little diverse area in Johannesburg. The Group Areas Act of the 1950s was enforced, which segregated South Africans by race. Black people were forcibly moved to Soweto, people of mixed race to Eldorado Park. My parents' families, or Indians, were moved to Lenasia. Lenasia at that time had no housing, so families had to live in military barracks separated only by curtains with no electricity or running water. Some families tried moving back to their old homes, but the government ended up demolishing those, so they couldn't move back. Here you can see some of the rubble from the homes destroyed. My father's family was also forcibly moved from Kliptown to Lenasia in a similar manner. It was in Lens that my parents met, married, and had 6 kids, I being the youngest. Apartheid dictated every part of our lives, from which hospital we could be born in, the clinic or schools we could go to, what jobs we could take, which restaurants and bathrooms we could enter. Even the beaches were segregated. And if we were to die, it determined which cemetery we could be buried in. We were separate, but clearly not equal. My father, who was a preacher, established the first church in Lenasia. I grew up watching my parents constantly running to the aid of their community, sometimes loading those that were sick or injured into our little car and rushing them to the hospital. Clearly, my inspiration for becoming an NP. November 11th, 1985, my parents, along with us 6 kids, 17 suitcases, and not much else, arrived in New York after a 17-hour flight from Johannesburg. We were thrilled to be away from the legal system of apartheid, but little did we know, racism, although illegal in the US, was alive and well. I graduated from SMU's F&B program in 2003. Back then, our classes contained approximately 3 people of color in each class. I learned so much at SMU, but there were questions in my head that began to form. Whenever we talk about the incidence of chronic illness, I'd sink deeper and deeper into my chair thinking, oh dear, it's gonna be us again. I wondered, why was it that people of color always seem to have the highest incidence of these illnesses? Why was it our people that were dying at such young ages? Why was it us that appeared to be a burden to society when we gave so much? Were we cursed or something? November 2018, my dad and siblings published our first book, The 17th Suitcase, which details our experience in South Africa and our move to the US. November 11th, 2019, I defended my DNP project at SMU. Today, I'm privileged to share that with you. What a joy and honor to be presenting at the very first annual DNPs of Color conference. The purpose of my study was to evaluate racism-induced PTSD symptoms in African-American women at Roots Clinic in Oakland, California, post a pilot program for NET. But first, some background. So what is racism? Racism is a type of discrimination based on a socially constructed racial classification by phenotype of eye look. It can be intentional or unintentional. But what does racism have to do with health? In a systematic review and meta-analysis, Paradis and colleagues reviewed 333 studies. The researchers determined that racism's effect size revealed poorer mental, general, and physical health. So exactly how does racism affect health? Allostatic load is an objective measure of the additive biologic strain on the body through the continuous adaptation to physical and emotional stress. High allostatic load is predictive of poor health outcomes and is a risk factor for chronic disease. Perceived discrimination or racism positively correlates with allostatic load level, especially when we control for the regular stressors that everyone else faces. African Americans, especially highly educated African American females, had higher scores of allostatic load at all ages compared with Caucasian Americans or other race or genders in the US. African Americans have higher incidences of all of these illnesses, including PTSD. In the past, when asked, why do these disparities exist? The only answer we had was that it was genetic. Well, you were just born with it. When in fact, it was actually epigenetic. Epigenetics is the study of how the environment can change the way our genes get expressed. It's now estimated that 70 to 90% of illness risk could be the result of environmental or socioeconomic status factors. What we now know is the social or structural determinants of health, racism being one of them. So how does trauma affect our genes? Yehuda et al. Studied Holocaust survivors. They found traumatic genetic mutations encoded in the genes of not only the survivors of the Holocaust, but in their offspring as well, who did not experience the same Holocaust traumas. But do these genetic mutations affect health? The longevity of the survivors of prisoners of war's sons was studied after the Civil War had ended. Their longevity was 1.1 times less than their brothers born before the Civil War, as well as 1.1 times less than non-prisoners of war survivors. So we can see that genetic mutations from trauma can not only be passed down to the next generation, but can also negatively affect health in the generations to come. Imagine the traumatic effects of the caste system, apartheid, slavery in the US, Jim Crow laws, redlining, major and microaggressions on the genes of African Americans and people of color today. Racism trauma can result in PTSD or PTSD-like symptoms. So what is PTSD? It's a mental health disorder that develops after experiencing or being a witness to a traumatic event. Most often associated with war traumas, the DSM-5 now recognizes that anyone experiencing a traumatic event could develop PTSD. It affects 3.5% of the US population and is more common in females. The prevalence of PTSD is 9.1% in African Americans compared with 6.8% of Caucasian Americans. In African American veterans, 27%, 13.7% in Caucasian American vets. African Americans are 1.5 times more likely to drop out of PTSD therapy, hence a need for sustainable therapy in this group. Signs and symptoms are negative thoughts and feelings, intrusive thoughts, avoidance, arousal symptoms regarding the trauma, like flashbacks and nightmares and so forth. PTSD is the most common mental disorder among African Americans aged 55 and older. So what are we doing to treat PTSD? Well, there are several therapies for it: cognitive behavioral therapies, prolonged exposure therapy, and so forth. Even though a second-line therapy, for this project, I chose NET. And the reason why I'll explain later. But what is NET? So NET is a desensitization therapy for PTSD that allows patients to process not only one, but multiple traumatic events through the narration of their own life story from birth, revisiting the traumatic experiences through the telling and retelling of their story. It focuses on processing particular elements of trauma, then and now, so cognitive, sensory, physical, and the emotional impact on their lives. So why NET? Compared with other therapies, I found it to be cost-effective, short-term, culturally sensitive, had excellent retention rates, and it also allowed for the processing of not only one, but multiple traumas, micro and major traumas. Seemed to be fitting for racism trauma. The American Psychological Association is currently considering NET to be a strong recommendation for the treatment of PTSD. So Roots Primary Care Adult Clinic is located in East Oakland on International Boulevard. It's a privately owned 501c3 nonprofit clinic. Their mission is to eliminate health disparities. Most of the patients are African American, publicly insured, and fall below 200% of the federal poverty line. Providers include all the providers that you see here. We also have a faculty practice, SMU runs a faculty practice staffed with family nurse practitioner faculty like myself and students that have been providing care there for several years. You see the clinics that Roots has. We ran this project at the adult clinic. Roots is located in a densely segregated area that's disproportionate by race. African Americans make up 6% of the Bay Area's total population. East Oakland, on the other hand, is 51% African American, which is where Roots is located. So this was a quality improvement study with a pre-post test design. Here you can see the inclusion and exclusion criteria. Recruitment was done by myself and 2 F&P students, as well as the LCSW. The patients were identified through the AHR or else referred by the clinic staff. They were recruited via phone call and then mailed an informational flyer and invited in for screening. Since the therapy itself involved processing trauma, we excluded patients that were already in severely stressful situations. Recruitment was extremely difficult on a short timeline, as stigma affected participation in this study. Understandably so in this population, considering medical atrocities of the past. We managed to recruit 4 patients, 3 completed the study. We collected both quantitative and qualitative data. I'll be sharing the quantitative data with you. So the CAPS-5 is the gold standard for diagnosing PTSD. It measures clusters of symptoms evaluated for frequency and intensity, which is calculated into a severity score. We use this total symptom severity score as our main outcome. It is very well validated and reliable, as you can see. Problem with the CAPS is that it does not assess racism specifically and is not culturally sensitive. Racism surveys that are well validated and reliable do not adequately assess DSM-5 criteria. So there is a gap in instruments that measure race-related stress linked to DSM-5 mental health outcomes. The University of Connecticut Racial Ethnic Stress and Trauma Survey, or the UNREST, is a clinician-administered interview for the identification of racial traumas. It has a racial trauma checklist that is well validated for use in African-American populations, but it's not fully validated for use in PTSD as yet. It attempts to bridge the gap by combining culturally sensitive racism measures and PTSD DSM-5 diagnostic criteria into one efficient measurement scale. While the UNREST is in the process of validation studies, questions used are extremely similar to the CAPS-5. Therefore, we use the CAPS-5 gold standard for scoring while modeling the UNREST questionnaire. Here you can see our implementation plan, the planning phase, which involved IRB exemption, net training, and recruitment and screening. Then the implementation, where we ran the net sessions, did pre and post testing. And then evaluation, where we did data analysis and reporting in the timelines for each. The first visit involved intake, informed consent, pre-testing with the UNREST and the CAPS, and then timeline development. And this is a patient, actual patient timeline. We provided the patient with synthetic flowers and rocks and adapted net to use ribbon instead of a rope to avoid imagery of a noose that could trigger a trauma response. So instead we used ribbon. The ribbon was laid on a table by the patient as a symbol of their lifeline. The patient then placed rocks and flowers along the ribbon continuum. They identified these with the name of an event and the age of the time at the time of the event. Racist events were labeled with a blue post-it note, as you can see, and a decision was made between the provider and the patient to determine which traumas we would address in the weeks to come. So here you can see the second visit was where the narration began in a chronological order from birth through the first trauma. The focus was on the 4 elements of NET, then and now. The stories were de-identified, recorded, and then sent to a scribe who typed and sent them back to us before the next visit, and clinical notes were taken at all 6 sessions. This work was particularly similar to the experience we had interviewing my parents and writing parts of my dad's book. It was a very emotional and fulfilling experience that closely connected me to my family and now to my patients for a lifetime. The 3rd, 4th, and 5th visit involved reading the story back, editing with the patient, and continuing the narrative story through current times. On the 6th visit, we did post-testing, read the story back and presented it to the patient in a written form, as well as a participation gift. And now for the results. So the CAPS-5 total severity pre and post-test scores are listed here. So you can see our 3 patients. Participant M, as you can see, here was her pre-test score and her post-test score. When you look at this, you think, wow, her scores decreased by 100%. But when you consider that her pre-test scores were very low, you can see that she's an outlier. But what we did learn is that her scores didn't get worse, and neither did any of the other patients. Patient L was a 20-year-old college student who was intelligent, energetic, lots of thoughts on racism. She was constantly analyzing her thoughts. You can see her pre-test scores of 38 decreased down to 16 post-test for a percent change of 58%. Patient J was a 41-year-old female She was very expressive, animated. Her narrative just flowed. You can see her pretest score went from a 36 down to a 9 for a 75% change in total severity score. So we're very pleased with the results. Not part of the study, but of note, the symptom clusters that make up a diagnosis for PTSD are scored on the past month version. We use the past week, but if I transferred those scores over to the past month's version, which was the exact same questions, without even multiplying it over 4 weeks, what we found was that prior to therapy, these two patients would have had a diagnosis of PTSD. Post-therapy, both of them no longer had a diagnosis of PTSD. In this NET pilot study, although small, we used NET to try to process trauma and decrease stress and allostatic load and attempt to bridge gaps between racism and mental health. And hopefully this translates to physical health as well. But because this research is still fairly new, the lessons learned is that stigma can affect access to care. PTSD may run rampantly undiagnosed in populations of color. We barely or do not screen at all for racism traumas, yet people of color experience these regularly, even in 2021. We barely focus on or treat racism trauma. Racism tools that are closely linked to the DSM-5 are not yet completely validated or standardized. Therapies like NET, although used for trauma, may have some potential for racism trauma in this population, but of course we'll need to run larger studies to determine if this is generalizable. I hope that you will join me in this research, in taking this research a step further and answering some of the questions yet to be discovered. While we didn't create these symptoms, it's our responsibility as healthcare providers to help fix this public health crisis and change an environment of intergenerational trauma into intergenerational healing through Ubuntu. As the Reverend Dr. Martin Luther King said, we may have all come on different ships, but we are all in the same boat now. Thank you for joining me today. If you have any questions, feel free to contact me at the contact information on this slide.